here for a long weekend to make sure there's an audience left. So I appreciate it. I know I'm the only thing standing between you and lunch and the baseball game. So I'm going to try not to bore you in the last hour with boring lab stuff. I hope to show you some things about what we do in pathology when we get a sample from an ocular melanoma patient or somebody thought to have a melanoma. Before I get started, I'm going to do a little bit, and you guys know a lot about this, and I'm a little challenged because Dr. Singh, who knows everything about the eye, is here, and I'm not an anatomist. So I'm going to give you my view of the eye, and then I'm going to take you to the cells. All right, so everybody knows what the eye looks like, and this is just, basic diagram here. What I'm going to show you on the next image is a real eye cut and cross section. So a histology of the eye, an eye that was removed. And we're going to go over these structures. So, oops, I did that prematurely. The ciliary body, the choroid, the retina, and the iris are structures that you will see in this human eye. So this is a cross-section of the eye that just kind of shows you basic anatomy. So I know you're familiar with the iris, gives color to the eye. Ciliary body changes, it has some muscle fibers, changes the shape of the lens of the eye. The choroid contains a very rich vascular network supplying the eye, and the retina in the most posterior portion of the eye. Here's a cross section to show the ciliary body. And what you can appreciate, you don't have to know everything that's going on here, but there's pigment here, right? The pigment is inside melanocytes. So the melanocytes make the pigment. Pigment protects the eye from the damaging rays of sunlight. This is the choroid, which is where most melanomas of the eye occur. And this is a rich, there's rich vascular connective tissue. And again, a layer of pigmented cells, which contain melanocytes. And this is the retina, that the photoprocessors basically of the eye that turn the light and the images that you receive into electrical impulses that go to the brain and actually generate an image. So ocular melanoma, as you know, is a malignancy of melanocytes originating in the eye. It's the most common primary tumor of the eye in adults, and it's pretty rare. The approximate incidence is about 1 in 5.2 million people per year. It's a disease generally of middle age and older patients, 50 to 70 years most commonly, but we have seen cases in children, although it is rare. Generally, ocular melanoma is unilateral. The choroid, which I showed you on cross-section, is the most common location for ocular melanomas. And that's, this is a diagram of that. And then ciliary body is number 2, followed by iris. Risk factors for melanoma are fair skin, a light color of the iris, so fewer melanocytes in the iris give you a blue eye, more melanocytes, a brown or darker colored eye. Congenital ocular melanocytosis is a congenital increase in melanocytes in the eye. That is a risk factor for ocular melanoma. BAP1 or BAP1 tumor predisposition syndrome. Arc welding is a risk factor for melanoma. And then all the other risk factors for melanoma, for skin melanoma, are into play here: age, male, and sunlight exposure. As you know, probably better than I, there's a variety of symptoms that can be associated with ocular melanoma. 50% of patients will have some type of visual symptom, a floater, a flash, or a defect in vision. But 50% of patients melanomas are discovered on dilated eye exam in patients without a symptom. They show up in their optometrist or ophthalmologist's office, and they find and it's found. Imaging is very good to identify melanomas, and these include ultrasound and ocular coherence tomography. You might wonder why I'm even talking about biopsying an eye melanoma when it's only needed in a minority of patients. Most of the time, Dr. Singh can use his clinical judgment. He can use the imaging data that's available to him, and he can say, you have melanoma. So many of you in this room maybe not have had a biopsy to say that you have definitely melanoma. Most of the time, the diagnosis is made on clinical basis. So when do we, or why would you have to have cells come to a pathologist to say, boy, this is a melanoma or this is not a melanoma? It's only in those scenarios where the clinical exam has some features that are not the norm. So when an accurate diagnosis can't be established on clinical grounds, something atypical in the presentation, possible metastasis. So that's generally when in a patient who's could have a tumor from another site traveling to the eye. That's one of the main reasons that we'll sample a tumor that may be a melanoma. And sometimes a patient wants it before having treatment that's going to change your life. Sometimes a patient wants to say, yeah, I want this confirmed with a tissue specimen. So how do you sample the eye? I'm a cytopathologist, and so cytopathologists we interpret fine needle aspiration. So very skinny needle put into the eye tumor to obtain some cells. This is a minimally invasive method, and it's very good at sampling small tumors. If we don't get a diagnosis because we don't have enough material or for some other reason, we have the opportunity to do a tissue biopsy as well. That's a second way to sample the eye. And that's usually used when an FNA or fine needle aspirate is not diagnostic. And then in certain instances, as Dr. Singh mentioned earlier, size is a big thing in melanoma diagnosis. If a tumor is large, sometimes we will have to remove the eye, and then we'll make a diagnosis by looking at the eye under the microscope. So who does ocular pathology? So we have a variety of people here. We have ocular cytopathologists, so cytopathologists who are certified in cytopath and who, like the eye in particular, find it challenging. We have a couple of ocular cytopathologists here. We have ocular surgical pathologists. Those are surgical pathologists who are trained specifically in neuropathology. So their practice is strictly tissues from the eye and from the brain. They deal with the tissue biopsies and the eye enucleation specimens. And I say oncologist and Dr. Singh's team because we work together. We don't do anything by ourselves. We talk constantly. Dr. Singh and I always talk before we get a specimen, and then we talk sometimes while it's processing, and then sometimes, well, we definitely talk again after I look at it. So what are the keys to success? How do you know your sample is going to be handled in a way that's going to make the most appropriate diagnosis for your care? It's very important that we plan what we're going to do before we receive our first specimen. So we don't want your sample to be the first one we've ever received without even knowing it was coming, right? We plan out everything in advance. We know what Dr. Singh is going to do. We know what he's going to want, and we know what we need to do to make sure we have everything we need in advance to make up an appropriate diagnosis. And we know who's in charge of what. So it's really essential that your pathologist has some experience, that they know what's going on with ocular specimens. It's very hard to take somebody who has never seen an eye sample before and thrust them into this situation and expect to get a diagnosis other than atypical cells. That's kind of a wastebasket that nobody likes. The pathologist hates it. No one likes it less than Dr. Singh. But we always check in with our ocular oncology colleagues, especially if something is unusual with a patient. So why cytopathology and why fine needle aspiration? Cytopathologists are expert in dealing with small samples. We specialize in a few cells. As surgeries and endoscopies become less invasive, we get smaller and smaller tissue specimens. So sometimes we have 10 cells. And so that's kind of where we come in. We know a lot of people throughout the hospital because we are often on site. Sometimes, in some organ systems like the lung or the pancreas, we go to the procedure and we make sure that there's enough material before the patient even leaves the room. We do that because triage, or figuring out what are we going to do with the specimen, is an essential role in when you're dealing with a specimen that has limited material. So is fine needle aspiration a good test? Is it worth undergoing? The accuracy rate for uveal melanoma is over 90% with an experienced team. And the accuracy of diagnosis is directly proportional to the lesion size. So the smaller lesions are harder to sample and they're harder to diagnose. But we still have a pretty good accuracy rate. We're also able, in those cases where a patient might unexpectedly have a metastatic tumor to the eye, where we have a 70% success rate in identifying the primary tumor, saying, hey, this is not a melanoma, this is a metastatic lung carcinoma. And so it is a pretty good test. Cytopathologists always must interpret the features that they're seeing on the slide in the context of what's going on with the patient. So we have to know what's happening. We have to communicate with our clinical colleagues. What are the problems with fine needle aspiration, though? It said it was about 90% accurate. It can have a false negative rate. And that's usually due to limitations in the number of cells collected. A negative diagnosis, therefore, should never be considered proof that a tumor is absent in the eye. It just means that the specimen might not have been cellular enough for us to make a diagnosis. If you get a positive diagnosis, so the report says, okay, this is melanoma, that's very, very rare to be falsely positive. And the concordance rate when we have a FNA sample and a biopsy sample, a tissue sample, approaches 95%. And therefore, a positive result on a fine needle aspiration can be relied upon. So I mentioned that an essential role of cytopathology is triaging a specimen. What is exactly triage? Triage means that we anticipate what might be needed in advance in addition to the microscope study. And that allows us to make sure there's enough sample allocated for all additional tests that might be needed. And the key to accurately handling a sample from the eye is preparing in advance for unexpected results. We always talk to Dr. Singh, and we always know what he thinks is going on, but we always keep an open mind and say, we're going to let the cells tell us what is really happening here. Here at the Cleveland Clinic, we're blessed with a surprise every week, or more than one. We have people with more than one diagnoses. We have something unusual weekly that I've never seen before. And I've been here 30 years, and that is the beauty of practicing here. You never can rest on your knowledge because something out of the ordinary is bound to happen. So what do we need to know from Dr. Singh? We need to know why the sample is being collected. Something clinically doesn't fit. We like to know if there's a prior history of malignancy, if that's available, or a prior history of any type of other therapy. We like to know the imaging results, the lesion location, and the size of the tumor. And most importantly, we want to know, what does the ocular oncologist think is going on? That's really the most important thing to us. Most of the other stuff we can get from the record, the medical record that's in the computer, but we really like to know what is really happening here. So when we collect a fine needle aspiration from a small sample, we take the needle, Dr. Singh will put the needle in the tumor, he'll take the needle out, and he'll rinse all the cells he collects from that needle into a liquid. You can do that in a variety of ways. I'm going to show you what we do here, but there's a variety of ways. And the only thing we really need to know is that these methods are methods of concentrating the cells. So these methods are methods of taking and making sure you're seeing absolutely everything that's in this specimen. At the Cleveland Clinic, we use something called Cytolite, which allows us to make a monolayer preparation. So the needle will be rinsed, all the cells collected. The cells are collected in the tip of the needle. The tip of the needle is hollow. So when the needle enters the tumor, cells are shed. Usually we move the needle back and forth a couple times. I'm not sure how often we do that in the eye because we don't want any bleeding or other complications, but the hollow point of the point of the needle is hollow, and cells by shear forces get stuck into that needle, and we rinse all those cells out into a liquid media. That's what we're doing. Then we take those cells and we make sure we look at absolutely every cell that's in that sample. And we do that by using a processor that collects the cells on a filter, which is what this, oops, I keep using the arrow as a pointer. This is a little filter right here. And the cells are, they're mixed, and then they are using a vacuum pulled through the liquid here up into this filter where they are adherent to the filter. They stick to the filter, and the filter will collect up to 10,000 cells. Now, Dr. Singh is really, really good, but there's never 10,000 cells in an eye sample. So we will fill that filter till there's no cells left. And that's what we do. And then we take that, this filter prep, and we place it on a glass slide. And again, using a vacuum, the cells are transferred from the filter to the glass. And we make a slide, and the cells are in a single layer in the center of this glass slide. Why do we use these methods? There's standards. It's a standard processing. It's not subject to a lab tech who might be having a good or a bad day. You know, their technique doesn't matter. It's the instrument. It provides excellent cell preservation, so we don't have to worry about cells drying out and not being visible anymore, or crushed or something like that. There's a very even cell distribution in a background that removes blood and other things that could interfere with the detail of the cells. So what happens to the slide once we make it? We stain the slide. We have a variety of stains. We use a Papa-Nicolau stain for our eye specimens. The slides are then screened by a cytologist. So that's a specialized technologist who looks at slides and marks abnormal cells. The slide then goes to me, and I look at the slide and I make the diagnosis. We review the patient's clinical history, and we pull any prior material that we think might be helpful that's in our files. So if somebody has a history of another tumor, we'll take those slides of that tumor and we'll look at those at the same time we're looking at the eye sample. At the Cleveland Clinic, we have a lot of residents and fellows. So at the time, and cytology students. And so at the time, before your slide gets to me, there's usually 4 or 5 other people who have looked at it as well. All right, so under the microscope, this is biology 101. I'm taking you back to your sophomore year of high school. And this is a cell. So I'm going to show you some cells, but I wanted to show you a diagram. I will put a disclaimer that I made a cell for my nephew. I look at cells all day, every day. I made an epithelial cell for him for a science fair project, and we got a B. So I feel like a bit of a fraud up here. He was told that his cell was not creative. So I'm gonna show you. So this is a cell. Yeah, you can believe me, or we can go back to our bio text. Okay, so a cell. This is the whole cell. The cytoplasm is all this pink stuff with all these. The cellular machinery is inside the cytoplasm of the cell. The nucleus is this yellow structure here. And the nucleolus is kind of the command center of the nucleus. When the cell is all revved up, you can see a nucleolus. And these guys are just to show you that, cells can have a variety of shapes and sizes. And it is based on what their function is. So, and here's some normal cells. So I want to, sometimes we hit a normal structure with our needle on the way in. This is the retina. It's kind of a, maybe you've seen pictures of retina. They have multiple layers. That's a little piece of retina. These guys are normal. I'm gonna show you what abnormal is. But I also wanted to show you what a melanocyte look like. Melanocytes make the melanin. So melanocytes make the pigment that protects the eye, as I mentioned. Melanin absorbs and scatters light and prevents it from damaging the retina. That's its purpose. And here is a cross-section of the retina. And here is a melanocyte ocular melanocytes have cytoplasmic processes, which are these things that are kind of dendritic cells that are kind of helping to connect it to the other cells around. So what do cells from melanoma look like? I'm showing you spindles. This is, my mom always wanted me to learn how to sew. I never did. So I took these from the internet. These are spindles. So I think and maybe somebody in here knows more than I. It seems like you wrap thread around these spindles. But the point of a spindle is that they're tapered, right? They have pointed ends. The top and the bottom are both pulled out. They are tapered. And melanoma cells, almost all melanomas, have some component of spindled cells that resemble these spindles, like this guy. Tapered end, it looks kind of like you stretched the cytoplasm. The nucleus is the blue thing in the middle, right there, right at the tip of the arrow. The cytoplasm is this skinny, tapered material at the end of the nucleus. And that's very helpful. It's also to us, it's also very helpful that we see pigment. And almost in other tumors and things, there are not these brown specks. When a tumor makes pigment, that's a clue to us that it is a melanoma. What does uveal melanoma usually look like? It's usually bland looking. So if you take a melanoma from the skin, you know right away it's malignant. They look very atypical, very bad. You know, this is a bad tumor. In the eye, melanomas look different than they do in the skin. In the eye, we call them bland. They can wreak havoc, that's for sure, but they don't have the same atypia that they do in skin melanoma. Most ocular melanomas have a component of spindled cells, so we use that to help us make a diagnosis. And some have pigment, which is very helpful when it's present. Not every eye melanoma has pigment though. There's also another cell type that's present in melanoma called an epithelioid cell. It's a melanoma cell that looks more plump and round. And often they're an admixture of both cell types. So I've just kind of shown, illustrated here all the different types of melanoma cells. So here's one that's all of the spindle cells. And here's one that's all of the plump round cells. And then many times there's a mixture of both, which is at the bottom panel right there. And this is just a higher magnification to show the spindle and the epithelioid. And both of these have pigment. You can see here, there's a lot of pigment. There's some pigment in this cell. There's some pigment here. And the pigment here is a little more sparse, but there is some pigment, which is helpful to us. Now, iris melanoma, if anyone has had a melanoma of their iris, that's a different animal. It's a subset of melanoma that has a benign course most of the time. Usually these tumors occur in young patients and the tumors are small. They're diagnosed at an early stage and they're very, very bland. The 15-year survival of iris melanoma is over 95%. So that's a bit of a different bird. And then here is an image I thought to put in for completeness that is from an eye that's been resected. So here is a tumor. It's a mass in the eye, and this is a enucleation specimen. And at higher magnification on this side, there is pigment and spindled cells, which you're now expert in seeing. And so this is an ocular melanoma that was resected. So what happens if we look at the cells and we don't know if we're right about our diagnosis, or we just don't know if the tumor is melanoma or not? What can we do? Not everything is black and white for us. And we have to use some tools at our disposal. One thing we can do is make a paraffin tissue block. So we take cells, we spin them down, we embed them in paraffin wax, which I know sounds very weird if you're not a pathologist, but that's what we do every day. We embed them in wax and we cut very thin sections. The wax just stabilizes the cells so we can cut sections. And then we look at those under the microscope. We stain with a different stain on these. And this is what it looks like. This is a paraffin tissue. This is wax. And this is the spot of cells. So there's cells right there. And we take and we cut those cells and we put them on a slide. And this is what the material looks like under the microscope. And this happens to be a lymph node. This is a benign lymph node. We make a cell block or a paraffin block in cases where we need to stain the cells. And we stain using immunohistochemical stains. We take advantage of the fact that all tumors, melanomas included, express structures on the outside of the cell that we can make antibodies to. So we have melanoma, we have melanoma tumors express certain things on their surface that we can make that we have antibodies to, and we can detect, and we can say, this doesn't really look like the typical melanoma, but it's expressing all of these melanoma antigens, we call them. And melanoma's signature is different from all of the other tumors that can happen in the eye. So then it can help us say, absolutely, this is melanoma. Usually we don't have to do this because usually we can tell by just looking at the cells and talking to Dr. Singh about the history, and we're confident in our diagnosis. But sometimes we have to use immunohistochemistry. We have to use immunohistochemistry. Immunohistochemistry of these stains are highly sensitive and highly specific, meaning we can when we do these stains, we rely on the results. And we prioritize the stains that are the most helpful. And we do that so we don't waste any of the cells that we have. We don't want to do a lot of things that are not necessary and then have the thing that is necessary not have enough cells. So we really try to minimize what we do and maximize the result we get. And I just wanted to show you that there are certain things that are specific to melanoma that are not on any other cell type, and that those are the antibodies listed here. And so if any of these, SOX10, HMB45, S100, if those are positive, we know it's melanoma. And what we do here at the Cleveland Clinic is we take the cells, if we can't make a cell block, we don't have enough in the paraffin, we can take cells right from the slide. I showed you the spot. We take them right off the slide and we do the stains right on those cells. So number one, we know the cells are there. And we know we have enough. And we don't have to go through this process because that would be really, really boring. But we can, suffice it to say, we can use the cells we've already seen. We can take those cells off a slide and we can use our stains if we need to. And here's an example. This is a patient who had a tumor from the kidney in the eye. And we didn't know what was going on, honestly. So it's weird to have a kidney tumor metastasize to the eye. We tried to make a paraffin tissue block. We did not have enough material on that. So we took the cells right off the slide we used to make the diagnosis. And this is the melanoma marker. It's not brown. Brown means expressed. So this is not a melanoma because this is not brown. It's something else that expresses other markers that are specific, in this instance, to a kidney cancer. So we have those types of tools at our disposal. So in the last few minutes, I'm going to show you some real cases, but I wanted to first say, this is what we do when we look at a slide. How do we make the diagnosis? We know what's going on clinically. We communicate. We consider the possibility of something other than melanoma. Make sure this is not a metastasis from another tumor. And we do that by looking for our spindled cells and we look for our pigment. Practically speaking, that's what we do. If we have anything in our files on a particular patient, we take it out and look at that too. And then we use our special antibody stains if we need to. I'm going to skip the molecular because Dr. Singh already talked about it and you guys know all about that. And I'm going to get to our cases. Excuse me, I'm getting over a cold, and I was hoping that wasn't going to happen. Okay. The first patient is 20-year-old man who presented to his ophthalmologist because he suddenly lost vision in the left eye. His physician noted a retinal detachment and a mass in his choroid. He had a family history for sure of cutaneous melanoma and possibly ocular melanoma. And he was referred to Dr. Singh. He had a large choroidal mass, and he had melanin observed in this tumor, and a fine needle aspiration was performed. And this is an imaging study to basically show you the tumor right here, relatively large tumor. And this is what this tumor looked like on the slide. It had our spindled cells even at this magnification. Now, you all will be able to make this diagnosis now. Spindled cells and pigment. And higher magnification, this pigment is really obvious in this tumor. And then our spindled cells here, and these cells have, here's one that has the blue nucleus, and the little pinpoint darker blue spot in there is the nucleolus. So that's also helpful. Melanoma cells often have nucleoli that you can see.
So that on the right here, were we looking at like 10 cells total? That what I don't know what I'm looking at here.
Yes, on this side?
Yeah, is that like 10 total cells?
Yes,
okay.
10 total cells.
Okay.
Yep, that's about 10 total cells. There's a few more here, maybe 25 or so, but yeah, 10 cells. You don't need that many if it has classical features, but yes, each of these, it's easier to count the nucleus because you can see that easier than the cytoplasm. So each one of these blue things is a cell nucleus. And this, we had a lot of cells to us, and so we made one of those paraffin blocks, and we stained that with a different stain called a hematoxylin and eosin stain. And I just threw that in there to show you that this, you can see the spindle cells and you can see the pigment. And this is probably 150 or 200 cells, so this is a larger sample. This patient was diagnosed with melanoma. And because of the large size, enucleation was performed, and he had gene expression profiling. He had a 1A, and his genetic testing was negative for melanoma genes. So that's a spindled melanoma. The second patient is a 56-year-old man who was thought to have retinal detachment on a routine eye exam. He was completely asymptomatic, had 20/20 vision in both eyes. He because of the concern for retinal detachment, he saw a retinal specialist who noticed a choroidal mass and referred the patient to Dr. Singh. There was a pigmented lesion that was visible in the eye with an irregular border, and he had a detached retina. And this was the size, 16.5 millimeters was the greatest dimension, and we performed a fine needle aspiration. Now this one has the more rounded cells, very few spindled cells and no pigment. So this one was a little bit harder, but in that field. So let's actually go back. So there's, 50 or so cells over here, a few less over here. Prominent nucleoli. You can see the round purple nucleus and then the denser area in the center. That's a nucleolus. Again, helpful. Most melanomas have prominent nucleoli. And we start seeing, there's a combination of cells. There's some spindle cells here. Now this is looking a lot more like melanoma. Some of those cells with tapered ends. So we diagnosed a melanoma. There were spindled cells and epithelioid, or the rounded cells. The patient had plaque therapy. He had a class 2 gene expression profiling result. All right. And the final case here is from a 70-year-old man. He came in with a diagnosis on the outside of choroidal melanoma from a retinal specialist. Really thought this man had a melanoma. He presented with some symptoms that included flashes for a few months. He had a lesion with no pigment clinically, so pigment was not seen, and he was put on the surgery schedule for an enucleation. However, Dr. Singh intervened and decided to, let's sample this. Let's make sure this is melanoma. So this is a very cellular specimen at higher magnification. There's not a single spindle cell in here, and there's none of those nucleoli we were looking for. There's some round cells, but it doesn't really look like a melanoma. Here's another higher magnification. You know, oops, sorry. This actually looks like it might be making a gland. It's got it's got nuclei around the edge, and in the center there's a hole. It's enough to raise our suspicion. Something weird is going on here. This is not typical of melanoma. Here's a little bit a higher magnification. Cells look a little bigger. There is a nucleolus in a couple of these, so we need to do some stains. So we took some of the cells off the slide, and we stained them with our brown stains. This stain is called a TTF1. You don't have to memorize the name of the stain, but this is a lung cancer marker. So this is a marker characteristically expressed by adenocarcinomas of the lung. And it's importantly absent in melanoma. So if this was a melanoma, this would be completely blank. So this is a lung cancer. This was not a melanoma. And that just shows you that sometimes these cases are very challenging, right? And if you need to be at a place that can hopefully separate the two, because this patient did not know he had a lung tumor until this eye sample was received. So those cases, I think, illustrate the kind of the tough times where it's important to sample an eye. We have to make sure we're right. And the conclusions of my talk are that you can make a diagnosis of ocular melanoma, that we need to use every tool that's available to us, and it needs to be a multidisciplinary approach where we work really closely with our clinical colleagues. And sometimes we need to get tissue for diagnosis, and sometimes, as you already know about, for prognosis. But all right, so that's the end of my slides, but I am happy to take any questions if anybody has any questions about how do we make a diagnosis of melanoma in pathology.